Hello students, so welcome to Guess the Paper series of Radiology. In this series, we'll discuss the important previous year questions and we'll discuss it in a test and discussion form. So I'll give you a question with options and then we'll discuss all the things of that question in detail. So let's start with the first question. First question is an identification sort of thing because anatomy questions are very important from your FMG point of view. You'll be asked one or two anatomy questions definitely in your paper. So identify the red arrowhead in the given image. So the red is pointing towards what structure? It is a smaller structure and this is a superior mesenteric artery. Okay, so let's just label all the structures that we are seeing in this image. So the blue arrow is pointing towards aorta. This is the abdominal aorta. The red one is pointing towards superior mesenteric artery. The arrow that I have marked is pointing towards the superior mesenteric vein. So remember, SMV is to the right of SMA. So radiologically, this is the right, correct? This is the left. So always remember, SMV is to the right of SMA. Okay, this relationship is always maintained. And in which pathology is this relation reversed? That is, SMV is left of SMA. This is seen in malrotation. Okay, this is seen in malrotation. Now let's complete the other structures that we are seeing in this image. So the arrow is pointing towards a duodenum. Okay, and we see that the duodenum is compressed between the superior mesenteric artery and the abdominal aorta. Okay, so this is known as SMA syndrome. This is known as SMA syndrome. That is the duodenum. Which part of duodenum? The third part of duodenum is compressed between the SMA and aorta, abdominal aorta. Okay, now let's complete the other structure. So this is the vertebral body. This is the right kidney, and always remember that on abdominal CT, the part of bowel with air within, this is always the large bowel. Okay, large bowel has fecal matter within and fecal matter has entrapped small bubbles of air. So this is the ascending colon. This structure here is the ascending colon. Likewise, this structure here, this will be the descending colon. This also has fecal matter within. Okay, so the answer to this question is superior mesenteric artery. Now let's just discuss the other anatomy of abdomen. So we'll label each and everything. So starting with the big structure, this is the liver, this is the spleen. Okay, this right here is the stomach. This is the stomach. This is the aorta, abdominal aorta. And this is the vertebral body. We know this. Right. Now moving on to the second image. Again, this will be the aorta. This vessel right here, this is the IVC. And just beneath the IVC, we have this right adrenal gland. This is the right adrenal gland. Which is the left one then? This triangular shaped structure, this is the left adrenal gland. This is the left adrenal gland. Now this structure right here is the spleen and this is the stomach that I have labeled. Likewise, moving on to the third image, we see that this cystic structure is the gallbladder. We've already labeled the liver, the right kidney, the left kidney, the aorta, the IVC, correct? And anterior to the aorta, we have two important vessels. On the left, we label it as SMA, and on the right, just adjacent to the SMA, we have the SMV. And we've read in anatomy that SMA and SMV are anterior to the uncinate process of pancreas. So which will be the uncinate process? So this whole is the pancreas, part of pancreas. Okay, so this will be the body of pancreas and this small structure here will be the uncinate process of pancreas. So this was regarding the abdominal anatomy. Now coming on to chest anatomy levels. So most commonly asked level for you will be at T4 vertebra. So if this is the T4 vertebra, correct? So what are the structures that we are seeing here? We know, we have read in anatomy that at the level of T4, the main pulmonary trunk divides into the left and the right pulmonary artery. So this is the main pulmonary artery. It is dividing into the right pulmonary artery and the left pulmonary artery. So this bright structure just adjacent to the vertebral body, what will it be? This will be your descending aorta. This is your descending aorta. And this structures anterior to, just adjacent to the main pulmonary artery, this will be your ascending aorta. This is your ascending aorta. Correct? These two will be your bronchi. I am labeling them in yellow. These two will be your bronchi. And these black structures, all these are your lungs. Now coming on to a lower section at the level of the heart, we have the four chambers of the heart. So we'll quickly label them. This will be your right atrium, which is opening into right ventricle. So remember, right ventricle is an anterior chamber. And what is this arrow pointing towards? This is pointing towards a moderator band. So remember, right ventricle is recognized by this moderator band. Now this black structure in the center, this will be your septum, intermuscular septum. And then the thick walled muscle layer, the thick walled ventricular chamber, this is your LV, and the arrow is pointing towards a papillary muscle. This is the papillary muscle. Now, which is the posterior chamber of the heart? Posteriorly located chamber of the heart is the left atrium. Always remember, left atrium is a posteriorly located chamber. So this was regarding the anatomy of the chest. Now we move on to anatomy of the knee, because two important ligaments have been repeatedly asked in various competitive exams. So first of all, whenever we are seeing the sagittal section of the knee, so this is a sagittal MRI of knee, correct? Both of them are. And in the sagittal view, we see two important ligaments, the ACL, anterior cruciate ligament, and the PCL, the posterior cruciate ligament. Now, anterior and posterior are described with respect to their attachment on the tibia. So, if the ligament is attaching on the anterior aspect of the tibia, this will be your anterior cruciate ligament. Likewise, a ligament attaching on the posterior aspect of the tibia, this will be your posterior cruciate ligament, or the PCL. Okay, now moving on to some important structures in the brain. So this is at the level of basal ganglia. Which structures are we seeing here? Now, which type of image it is? So first of all, it is an MRI image, correct? Why? Because your bones are black. And which type of MRI image is it? Since the CSF is bright, we'll easily call it T2 axial image. Likewise, the second image is also a T2 weighted axial image, because the CSF right here is bright. Now, what are the structures we are labeling here? This is caudate nucleus. This is putamen. The medial part, just medial to the putamen, we have globus pallidus. Now, both the putamen and globus pallidus, we know they form the lentiform nucleus. Now, in the midline, two big structures are there. These are the thalamus. Now, in between the basal ganglia and the thalamus, this blue structure that I am labeling, this is your internal capsule. This is your internal capsule. Right? Now, an important lobe I am labeling here. This. What is this lobe? This is the insular lobe or the insular cortex. Anatomically, it is taken as part of the temporal lobe only. But just beneath this insular lobe, we again have one white matter that is known as an extreme capsule. Extreme capsule. Now, the second section, we are taking it at midbrain level, at the level of midbrain. So, at the level of midbrain, we know that we divide midbrain into tegmentum, which is the anterior part, and the tectum. And that division occurs at the level of aqueduct of Sylvius or the cerebral aqueduct. So, if we draw a line passing through the cerebral aqueduct, the part of the midbrain posterior to it will be the tectum. So, this is the tectal plate which has the superior and the inferior colliculi within. And the part of the brain, midbrain, which is anterior to this cerebral aqueduct, this is the tegmentum. Now, this tegmentum further has substantia nigra, which is this black colored area within the midbrain. So, this will be your substantia nigra. And anterior to it, we have another corticospinal tract which form the cerebral peduncles. These are the cerebral peduncles. So this was regarding the midbrain section. Now at the level of midbrain, we have these big ball-like structures in the interpeduncular fossa. So this is your interpeduncular fossa. What are these ball-like structures? These are nothing but your mammillary bodies. Very important. Okay. So this was at the level of your midbrain. Now we discuss some orbital section because again questions on orbital anatomy and labeling of extraocular muscles have been repeatedly asked. So we know that these are the two orbits, right and left. So this is your right side, this is your left side. And what is your eyeball known as anatomically? We call it globe. So the part of the globe anterior to the lens is the anterior chamber. This will be your posterior chamber, correct? Now let's label the extraocular muscles. So the medial muscle is your medial rectus. Lateral muscle is your lateral rectus, correct? Similarly, if you look at this T2 weighted axial MRI, T2 weighted axial MRI, what structures do you see? You see this again, medial rectus, lateral rectus, optic nerve. This structure is the optic nerve. And then we have your globe with the anterior chamber, posterior chamber, and the lens. Now, on a coronal T1 weighted image, so listen carefully what sequence I'm telling. This is a T1 weighted coronal image of the brain. Why T1 weighted? Because the CSF in the brain is black. So this is a T1 weighted image. So what are the various extraocular muscles that we are labeling? So this is the inferior rectus, the lateral rectus, the medial rectus, and the superior rectus. Now, which are the oblique muscles that we are seeing here? This muscle right here, this is the superior oblique muscle. And we know superior oblique is supplied by the fourth cranial nerve, that is the trochlear nerve, and the lateral rectus is supplied by the sixth cranial nerve or the abducens nerve. Rest all the extraocular muscles are supplied by cranial nerve 3. Right? Now, in the center of your orbit, we have the optic nerve. So this will label as optic nerve. So this was about the orbital anatomy, very important from your FMG and NEET PG point of view. Now let's move on to other question. The second question, the CT thorax represents what? So in this image, no history has been given. It's a direct spotter which has been asked. So here we see that the ascending aorta is number one dilated. Yes. And we see this intimal flap. This is known as an intimal flap, which is dividing this aorta into two lumens. This is one lumen and then this is the second lumen. So what is the diagnosis? This is aortic dissection. This is aortic dissection. And since the anterior aorta or the ascending aorta is involved, this will be an ascending aortic dissection. Now, in an aortic dissection, it's very important for us to, identify the true lumen and the false lumen, because the intervention depends upon wherein you put in the stent. So if you put in the stent in the true lumen, the false lumen will disappear and the dissection will be treated. However, if you put in the stent wrongly in the false lumen, you are inadvertently closing that artery. Hence, it is catastrophic. So remember, true lumen will always have a higher contrast, very bright contrast, because the contrast is in the true lumen. So this will be your true lumen. The area of the aorta which has less contrast, less bright appearing contrast, this will be your false lumen. Never go by the size of the lumen. So false lumen can be large because continuous blood is flowing through it and no blood is coming out of it. So the blood keeps on accumulating and it enlarges in size. So never go by the size. See the contrast density in both the lumens. Now, since we are on the topic of aortic dissection, we'll quickly discuss the classification system. So, Stanford divides aortic dissections into type A and type B. Simple. A is ascending aorta involvement. So, whenever you see ascending aorta involvement, it is always and always Stanford type A. Now, further, these have been divided by DeBakey into 1, 2, and 3. Now, if type A has everything involvement, everyone involvement, A है तो ascending aorta होगी, but arch, descending thoracic, abdominal, everything is involved. This is DeBakey type 1. ठीक है, so 1 is everyone is involved. Now 2 is only ascending aorta is involved. Now coming to Stanford type B. So type B will divide into A and B. DeBakey A and B. So A is above diaphragm. That is only the part of aorta which is above the diaphragm is involved. That is will be DeBakey type 3A. And if both above and below are involved, this is DeBakey type 3B. So this was about your aortic dissection. Now let's move on to the next question. An elderly male presented with multiple bone pains, anemia, renal failure, proteinuria, and hypercalcemia. So what are the buzzwords? First of all, it's an elderly male bone pain. So it's a bony pathology we are talking, but it has some systemic features. So what are these features? These are the crab features that we read in multiple myeloma, correct? And what do you see on the skull X-ray? You see these multiple lytic lesions throughout the skull, correct? So what is the diagnosis? So these multiple lesions can either be METs, multiple myeloma, hyperparathyroidism, but then you have to rely on the history also. So since this patient has anemia, renal failure, proteinuria, bone pains, and it's an elderly male, the most likely will go with the answer of multiple myeloma. So right at the outset, we quickly see all other important skull X-rays as well. So in hyperparathyroidism, okay, if the scenario of hyperparathyroidism is given, what kind of question will it be? So patient will have renal colic because there are stones which form in the urinary system. Patient will have bone pains because of the lytic lesions in the bone. He groans and moans because of hypercalcemia, which affects the CNS. So these are typical features which are described for hyperparathyroidism. And what is the appearance of skull that is seen in hyperparathyroidism? We call it salt and pepper skull, also known as pepper pot skull. Salt and pepper skull or pepper pot skull. Now, some other appearances of skull not related to hyperparathyroidism but comes as a spotter. So, this crew cut appearance or hair on end appearance. So, we call it hair on end or a crew cut appearance. This is seen in thalassemia. Okay, thalassemia, or in general, you can call it hemolytic anemias. Hemolytic anemias. So, hemolytic anemias will also include hereditary spherocytosis, hereditary leptocytosis, thalassemia, etc. Now, if you see on skull, big punched out lesions. So, the buzzword being a punched out lesion with beveled margins. With beveled margins. Then the answer will be eosinophilic granuloma. Eosinophilic granuloma. But in a skull x-ray, if you are seeing multiple lytic lesions with bone pain, with crab features like renal disease, anemia, proteinuria, etc., benchtone proteinuria, and plasma cell infiltrate on bone marrow aspiration or biopsy, then you know that you are dealing with multiple myeloma. Correct? And similarly, just last spotter of skull, and that is related to Paget's disease. Now, Paget's disease we know has a lytic phase and a sclerotic phase and a mixed phase. So, in lytic phase of Paget's disease, we get this well-defined large lytic area in the skull. This is known as osteoporosis circumscripta crani. So, this is seen in lytic phase of Paget's disease. And in mixed phase, we'll see this some areas of sclerosis, some areas of lysis within the skull. This is the cotton wool skull. This is the cotton wool skull. And it is seen in which phase of Paget's? The mixed phase. So this was about your various appearances of skull. Now, moving on to the next question. A 40-year-old male was brought to the emergency with severe abdominal pain. On examination, the pulse was 112 per minute and the systolic BP is 80 mmHg. So we know that it is hypotensive. The patient has tachycardia. So the patient has hemodynamic instability. Okay, patient has hemodynamic instability and a chest X-ray is given below. So what do we see on a chest X-ray? We see that there is air beneath the diaphragm, this crescent shaped air in the diaphragm or pneumoperitoneum, and this tells us that there is some perforation. Now, whenever there is a perforation and the patient is hypotensive, first is resuscitation, that is, you will give IV fluids, you will try to maintain the BP, give inotropes if necessary, but eventually the patient has to be taken into OT because the patient is going into sepsis. You have to stop the perforation. So the answer here will be exploratory laparotomy. The next step in management, appropriate step in management amongst the given options is an exploratory laparotomy. Now, since we're on the topic of pneumoperitoneum, let's read the various signs of pneumoperitoneum as well. So first is your Rigler's sign. So what does Rigler's sign say? Is that whenever there is extraluminal air, the bowel wall will be very well visualized because air is both outside and inside the bowel. So the bowel wall is very well visualized. This is your Rigler's sign. Now, some signs of massive pneumoperitoneum, very large air in the abdomen. So one of them is a football sign. Okay, the abdomen is in the shape of football. This is mainly seen in infants because they have small abdominal cavity. Now, if your air is beneath the central tendon of the diaphragm, this is known as the cupola sign. Okay. Similarly, in cases of massive pneumoperitoneum, the ligaments within the abdomen get outlined. So if your falciform ligament is getting outlined, it is known as the falciform ligament sign. And similarly, if your lateral umbilical ligaments are getting outlined, this is your inverted V sign. Now, another type of sign which is seen in small pneumoperitoneums is this triangular air which gets entrapped within the bowel loops. So, this is the telltale sign or the triangle sign of pneumoperitoneum. And if your air is in the Morrison's pouch, this is the Doji cap sign of pneumoperitoneum. Okay, let's move on to the next question. A 30-year-old patient presents to the casualty with after motor vehicle accident. He has bruises on his chest. His pulse is 100 beats per minute. BP is 125/85. That is, the BP is maintained. Respiratory rate is slightly tachypneic, 28. A chest X-ray was performed and is shown below. So what do we see on the chest X-ray and what is the most appropriate next step? Now here we see that there is this hypolucency, radiolucency involving the right hemithorax. So this tells you there are no bronchovascular markings. So this is not a normal lung. And this tells you that there is this massive right pneumothorax. We can also see the tracheal shift to the opposite side. Now, so we are dealing with a large pneumothorax. So what should you do? Should you put in a needle thoracostomy or should you put in an ICD? So it depends on the patient's clinical status. Since in the question, it is given that the patient is hemodynamically stable. So we have time to put in an intercostal drainage tube. So here we'll do a chest tube placement and drainage. But if it was an unstable patient, let's say BP was 85/50, patient is crashing, going into hypotension and shock. Now we want to immediately decompress the chest. We don't have time to put in an ICD. So we'll do in that case a emergency thoracotomy. I hope this is clear. So let's just quickly revise the various pleural pathologies. So one we have already read. It is pneumothorax. How do you identify pneumothorax? You see this visceral pleural line which is compressing onto the lungs, and outside this visceral pleural lines we do not see any vessels. This tells you that there is free air within the pleural cavity and we call it pneumothorax. Now treatment of pneumothorax, as we have already told, if stable patient will put in an ICD. If it's an unstable patient, we'll put in a needle thoracostomy. Now the second image, what do we see here? We see that the right CP angle is blunted. We see blunting of the right CP angle. So this tells us that this is a pleural effusion. And what is this sign that we are seeing here? This is the meniscus sign. But if you see air fluid level, you see a proper level within the pleural cavity, and outside this air fluid level we have free air. That is, we are not seeing any bronchovascular markings. So this is free air and there's a level. So that means that there is an associated fluid component as well. So this is a hydropneumothorax. So this is a hydropneumothorax and this also needs to be drained. So we'll put in an ICD, intercostal drainage tube. Now the next question, we've already read this. What does the following X-ray depicts? We know that the right CP angle is blunted and showing a meniscus sign. So this is a pleural effusion. Simple for us. Since we're the topic of chest X-ray, and chest X-rays are very, very commonly asked in your exams. So let's firstly label the various bones. How do we count ribs? Okay. So first of all, whenever you're counting ribs, remember you have to go from anterior to posterior. Okay, this is the rule. So how will we count the ribs? This will be our first rib. This will be our first rib. Likewise, this will be your second rib. So we are going from anterior to posterior. This will be your third rib. So we have labeled this as well. This is the first rib, the second rib, the third rib, and we are going from anterior all the way till the posterior. Anterior to posterior. This is how we count the ribs. Similarly, these are the two clavicles. This is the scapula, and in the center we have the vertebral bodies, which are very well labeled. On a lateral chest X-ray, what do we see? So we see that the anterior air containing structure is the trachea and the esophagus is posterior to the trachea. Now on a lateral chest X-ray, the most anterior structure is the right ventricle. So this is your right ventricle, and the posteriorly located structure is your left ventricle. This is your left ventricle. Correct? So this was about your lateral chest X-ray. Now aorta goes and from anterior to posterior. So this is how your aorta goes. This will be your aortic shadow, and the main pulmonary artery is shown with this yellow lines. Now on a chest X-ray, whenever you see a opaque hemithorax. What is an opaque hemithorax? That one side of the thorax has completely white out. So unilateral white out lung. We are reading the DDs of opaque hemithorax or unilateral white out lung. In such cases, we have to see the trachea. So if the trachea is ipsilateral, so we are labeling trachea here, we are writing trachea, and if the trachea is ipsilateral to the opaque hemithorax, that means that there is a pull towards that lung. So this means that there is a right lung collapse. Okay, but if the trachea is contralateral means it is pushed towards the other side. Why will it be pushed? Because there is a massive effusion or a mass which is occupying the entire left hemithorax. So this is either left pleural effusion or a large left lung mass. So for example, chest wall masses like Ewing sarcoma of the ribs can become so huge that they can occupy the entire left hemithorax or one side of hemithorax, and that is exactly how they look. So either a left pleural effusion or a large lung mass or basically a large chest mass. But if the trachea is in center, okay, so if the trachea is in center, so it is either consolidation or a pleural effusion with an associated underlying collapse of lung. So these are the DDs of opaque hemithorax. Moving on to the next question. Identify the radiological procedure shown below. So an easy question. So we see oral contrast going into the stomach. So this is the stomach. This is the duodenum. And then opacifying the rest of the small bowel. So the part just next to the duodenum, this is the jejunum, we know. And then we have this ileum. So remember, so first of all, which investigation is this? So it is BMFT or barium meal follow through. Now how do we identify jejunum? Jejunum has feathery appearance on barium meal follow through, whereas ileum is featureless. It does not have any feathery appearance. Now let's just see various barium studies and in fact various radiography and fluoroscopy images of the bowel. So first of all, we have already read this is the BMFT, right? In BMFT, what do we see? Normally the jejunum is towards the left and the ileum is towards the right. But if this relationship is not maintained, that is the jejunum is towards the right and the ileum is either in the pelvis or towards the left, that means that this is a case of malrotation. Remember, jejunum coming onto the right hand side is abnormal and signifies it being a malrotation. Such children are more prone to midgut. So such children are prone to midgut volvulus. Now, which is the next investigation? We see a tube in the rectum and there is contrast opacifying the entire large bowel. So this is a barium enema, right? And what do we see here? We see these small outpouching from the sigmoid colon wall. So this is nothing but diverticulosis. Diverticulosis. For diverticulosis, remember the investigation of choice is a barium enema. But if a diverticulitis is asked, then the investigation of choice will become a CECT. Okay. Now, which is this fourth image? So we see that the small bowel is getting opacified with barium, but we very well see the wall of the small bowel. And if you look closely, you will also see a small tube within the small intestine. So this is nothing but enteroclysis, barium enteroclysis. That if we put in a nasojejunal tube, this is a nasojejunal tube that we have put in, and after giving barium through that tube, we push in some air so that the barium gets stick to the walls of the small intestine, and we very well see the mucosal pathologies of the small bowel. So this was done in earlier times, but nowadays this has been replaced by CT enterography. So CT enterography will be the investigation of choice whenever we want to evaluate small bowel pathologies. For example, Crohn's disease, abdominal tuberculosis. For all these, we'll do a CT enterography. Now, which is this? The fifth image that is shown, the X-ray. So the child is lying upside down. So this is what we call it an invertogram. And this was used for diagnosis of anorectal malformation. So we basically put in a coin at the anal opening and we measure the distance between the highest level of the rectal gas and the coin. And if that distance is more than 2 centimeter, then we suspect a high ARM, high anorectal malformation. But nowadays, invertogram is not done because it is traumatic for the baby to be hung upside down. So what do? We do a cross table. Sorry for that. We do a cross table lateral view. CTLV we call it, cross table lateral view. Okay. Now, which is this last image or the seventh image? So here we see that we are seeing various layers. Okay, and whenever you are seeing various layers, you have to suspect that it being a bowel. And if you're very well able to visualize layers in circles, so it is an endoscopic ultrasound. This is an endoscopic ultrasound. Okay, now let's move on to the next question. What is the imaging modality that is given below? So here we are seeing that the small bowel has some fluid within it. So remember, whenever we give water to the patient to drink, that never distends the small bowel. Why? Because water gets absorbed in the intestine. So what do we do when we evaluate the small bowel? So for small bowel pathologies, remember we always have to do CT enterography, because here, which oral contrast do we use? We use either mannitol or polyethylene glycol, PEGLEC. We call it PEGLEC, right? And both of them are hygroscopic agents. That is, they absorb water. So the water will not get absorbed in the intestine, and the intestines will distend. So this is known as a CT enterography. And this is used for small bowel pathologies. So see how well the small bowel thickening and enhancement is seen here. And we see this prominent vasa recta. So yes, we are dealing with Crohn's disease. We are dealing with Crohn's disease, and this imaging modality, yes, it is a CT enterography. Okay. Now, which is this modality that is shown? First number, this is an MR enterography. Again, we are seeing very well the small and the large bowel, but the bones are appearing black. The background tissue is suppressed. So this is an MRI, MR enterography. Now, which is the second modality? This is barium meal follow through. We see that the barium contrast is in the small bowel and the large bowel, and we see these multiple strictures within the small bowel. And intervening these strictures, we have these normal areas of bowel. So what are we dealing with? We are dealing with multiple strictures and these skip lesions. Skip lesions meaning intervening normal bowel segment. So this is pathognomonic of Crohn's disease. Now in Crohn's disease, the type of strictures that we get are known as long segment strictures. Whereas in bowel TB, we again get multiple strictures, but they are short segment strictures. So just look at how a long segment stricture looks like. So this whole bowel starting from here till here is abnormal. And we see these prominent vasa recta. This is known as the Coombs sign. And it tells us that it is an active Crohn's disease. Similarly, Crohn's, we know that it's a fistulating disease. So in Crohn's disease, we have these enteric fistula which develop. And such enteric fistula, the bowel gets clumped to each other, giving a stellate appearance. Stellate sign of bowel is due to enterocutaneous fistula, and it is in fact due to clumping. It is due to clumping of bowel loops secondary to an enteroenteric fistula. So let's move on to the next question. Identify the view given in the X-ray. So whenever you are given a paranasal sinus X-ray, remember that you have to remember two important views. One is a Waters view. So that will be like this. The patient will be looking up. And remember that view, Waters view, is mainly for maxillary sinus evaluation. And another one will be a Cadwell's view in which the patient is looking down. That is mainly for your frontal sinuses. So what is this view showing? The patient is looking up for maxillary sinuses. This is a Waters view. So water W, आप उसको उल्टा कर दो तो M बन जाता है, M for maxillary sinuses. And apart from maxillary sinus, we also evaluate the inferior orbital wall here, plus the inferior orbital wall. So we'll quickly see two important PNS views. One is a Waters view in which the patient is looking up, and it is mainly used for maxillary sinus evaluation and orbital floor evaluation. Now, if your Waters view has an open mouth, so in addition, we can also evaluate the sphenoid sinus. This is known as a Pierce view. Similarly, if the patient is looking down and the X-rays are coming from behind onto the X-ray film, that is a Cadwell's view, and that is mainly used for evaluating the frontal sinus. Okay. Now let's move on to the next question. What is your diagnosis? So this is a Waters view that is given to us, and on the right side we see that the right maxillary sinus has this radio opacity within, and that is not present on the left hand side. So among the given options, what can it be? Orbital blowout fracture, orbital roof fracture. So roof is at the top, so it cannot be roof. Oculomotor nerve paralysis, that will not have a radiopacity in the maxillary sinus, and neither will a retrobulbar hemorrhage will have. So retrobulbar hemorrhage is also not the option here. The answer is a orbital blowout fracture. That is the floor of the orbit, there is a fracture, and because of that fracture, the orbital fat gets herniated through that fracture into the maxillary sinus. So somebody hits you, punches you in the eye. Okay, so suddenly there is increase in the intraorbital pressure, and because of that increased pressure, the inferior orbital wall, because it's very thin, it gets fractured and the orbital fat gets decompressed through that fracture into the maxillary sinus. This is what an orbital blowout fracture looks like. Okay. Now let's see the similar example on CT. A 5-year-old boy while playing got hit by a tennis ball and a CT scan is given below. What is the likely diagnosis? So again we see that the inferior or the floor of the left orbit has this fracture and the orbital fat is getting herniated through it into the maxillary sinus. Again, this is an example of your blowout fracture, orbital blowout fracture. Now moving on to the next question, identify the sign shown in the given image below. So first of all, this is a contrast enhanced CT. We are seeing very well vessels. This is contrast within the vessel. So this is a contrast enhanced CT. And we see that there is this big mass in the right pterygopalatine fossa and the pterygomaxillary fissure. So this right here, this is your retromaxillary fat, or this is your retromaxillary fat. Or your pterygomaxillary fissure. And you see this enhancing mass at this space. So remember, if you see a mass, enhancing mass in the pterygomaxillary fissure, you have to just think of one diagnosis, that is JNA, juvenile nasopharyngeal angiofibroma, JNA. A very vascular tumor, intensely enhances, very brightly enhances, and gives a mass effect on the maxillary sinus. So there is this anterior bowing, of the maxillary sinus. This is known as a Hallman-Miller sign, and this signifies that it is a JNA. It is seen in juvenile nasopharyngeal angiofibroma. So let's just see other similar cases. So one we have already discussed, that if there is anterior bowing of the maxillary sinus, this is your Hallman-Miller sign, and this is seen in, yes, JNA. Similarly, if there is a patient of chronic suppurative otitis media, CSOM, and he develops a new onset headache, seizures, epilepsy, etc., or a focal neurological deficit, then you get a CCT head or MRI head done. And if you see this ring enhancing lesion in the temporal lobe, remember, ring enhancing lesion in a background of CSOM, you always have to suspect a abscess. In this case, a temporal lobe abscess. This is usually a follow-up of CSOM patients who developed these temporal lobe abscesses secondary to extension of their infection. Now similarly, if you have an image of the coronal image of the paranasal sinuses, and within that paranasal sinuses you have these bright structures which are expanding the paranasal sinuses and the nasal cavity. So this is nothing but your allergic fungal rhinosinusitis. Okay, what are the buzzword here? That there is these hyperdense contents within the nasal cavity and your paranasal sinuses. Now, in allergic fungal rhinosinusitis, there is no bony erosions, in contrast to mucormycosis. Okay, mucormycosis is an angioinvasive fungus, and it invades and destroys the various bones, whereas allergic fungal rhinosinusitis does not cause bone erosion, it just causes bony expansion. So this is a fungal element that is present in a paranasal sinus. Now let's come to some bone tumors. A patient with giant cell tumor, which of the following is false? So yes, we agree it's a giant cell tumor. We see a lytic lesion in the epimetaphyseal location, and it is extending till the articular surface. It is extending till the articular surface, and it is eccentric in location, located on the one side. So yes, eccentric location, correct. Sorry, let me just change this. Yes, so eccentric location, correct. Defined margins, correct. Epiphysiometaphyseal location, correct. So chemotherapy is the mainstay of treatment? No. Curettage is done. So I will tell you in ortho that extended curettage or an intralesional type of curettage is done, but chemotherapy is not the treatment for a GCT. It's a benign tumor, so it is excised. Now, similar to GCT, if you see this lytic multiseptated lesion in the metaphysis of bone and before skeletal maturity, then this will be an aneurysmal bone cyst. This will be an aneurysmal bone cyst. Okay, so if in the question you are given a child a lytic lesion involving the greater tuberosity of humerus, or greater trochanter of femur, or epiphysis of tibia. So lesion involving the epiphysis or the apophysis. These tuberosities and trochanters are the apophysis, and the buzzword being a child. So remember, this will be a chondroblastoma. अगर चाइल्ड में एपिफिजियल लिटिक लीजन है तो कॉन्ड्रोब्लास्टोमा, एडल्ट में एपिफिजियल लिटिक लीजन है तो जाइंट सेल ट्यूमर. Now coming on to the next bone tumor, identify the diagnosis. So we see that first of all tumor is involving the small bones of hands, and जब भी question में या image में small bones of hands and feet का tumor दे रखा है, you have to only think of one important entity, that is enchondroma. Enchondroma is tumors of small bones and hands. Small bones of hands and feet. Now remember, if there are multiple enchondromas like in this image, so this is known as Olier's syndrome. Now if there are multiple enchondromas plus soft tissue hemangiomas also, then which is that syndrome? That is your Maffucci's syndrome. Correct? Now multiple exostoses. What are exostoses? These are osteochondroma. And what is this syndrome known as? This is known as diaphyseal eclasis. Coming on to the third option, brown tumors. Now brown tumors are seen in which condition? They are seen in hyperparathyroidism, and again they involve the large bones or flat bones. Polyostotic fibrous dysplasia. These also affect the large bones or the skull bones. And two important syndromes associated with polyostotic fibrous dysplasia. Two important syndromes. One is your McCune-Albright syndrome, and second is your Mazabrod syndrome. Okay. Now moving on to the next question. So this is your Maffucci syndrome. You see these multiple enchondromas and these soft tissue hemangiomas. These are how soft tissue hemangiomas look, because you can see phleboliths at this place. And this is how your Ollier's disease looks like. Multiple enchondroma in the small bones of hands. Okay. Now coming on to fibrous dysplasia, how does it look like? You see this shepherd's crook deformity of the femur, and it can also affect the craniofacial bones, where it gives this ground glass appearance. Okay, fibrous dysplasia has fibrous tissue, so it does not calcify like a normal bone, so it appears hazy. That is what a ground glass is called. So ground glass appearance seen in fibrous dysplasia in bones. Now if you are given a lytic lesion, okay, so if you are given first a lytic lesion and you are given this lesion in a diaphysis and the bone involved is tibia. So tibial diaphysis lytic lesion, one differential only, adamantinoma. Similarly, if there is a lytic lesion in the upper end of humerus, so the buzzwords being lytic, upper end humerus, metaphysis, and single locule, that is a unilocular cyst. So this will be simple bone cyst. And in simple bone cyst, we know we get two important signs. So signs, what are signs in simple bone cyst? One of them is a fallen fragment sign, and another one of them is a hinged door sign. Now some other bone tumors, if it is a sclerotic bone or a white appearing tumor, sclerotic bone tumor, and typically involving the craniofacial skeleton. In the craniofacial skeleton, most common it being a frontal sinus. So I'm talking about a sclerotic bone tumor, mainly craniofacial bones, and in the craniofacial bones, the frontal sinus being the most common. Then we are talking about osteomas, simple osteoma, correct? But if your patient profile is that of a young adult or even children, and in the question it is given night pains relieved by NSAIDs, and on an X-ray or a CT you see a central small lytic area and surrounding very good sclerosis, small central nidus surrounding good sclerosis, then the answer is nothing but an osteoid osteoma. Osteoid osteoma, correct? And what is the treatment for osteoid osteoma? You do a radiofrequency ablation. RFA is the treatment of choice. Now, coming on to the next bone tumor, if you see again a sclerotic lesion with well-defined margins coming out of a normal bone, that is, there is cortical plus medullary continuity, and the tumor is growing away from joint, then that is nothing but an exostosis or an osteochondroma, correct? Now this osteochondroma has a cartilaginous cap over it, and this has been previously asked, what are the features suggesting malignant transformation of this osteochondroma. So first of all, if the cartilaginous cap thickness is more than 1.5 centimeter after puberty, then that means that there is some malignant potential going on. And second, if the growth of this exostosis keeps on happening even after puberty, then that is also a sign of it being a malignant transformation. Okay, these are the two important signs. Now another bone tumor, malignant bone tumor involving the children. So if it's a child, malignant bone tumor, and you see this large soft tissue mass with this sunburst periosteal reaction, then the diagnosis is a osteosarcoma. Now one type of osteosarcoma has this fluid levels. So osteosarcoma with fluid levels on MRI, in which case it's shown, it is seen in telangiectatic osteosarcoma. Okay. Now, if you see a bone tumor in an adult or elderly, and this has multiple ring and arc type of calcification and a large soft tissue mass. So this is a malignant tumor because of a large soft tissue mass and these multiple ring and arc calcification. What does it tells you? It tells you that it has a chondroid matrix. So the diagnosis here will be chondrosarcoma. The diagnosis here will be chondrosarcoma, ring and arc type of calcification, adult, elderly, and location metaphysis. Now coming on to the next bone tumor. So if it's given that it is a tumor involving the child and it's involving the diaphysis of bones, and this tumor mimics infection in some sort of way. The patient can have redness, fever, erythema, and even raised TLCs, etc. So, and on an X-ray, what do you see? You see this lamellated periosteal reaction. This is known as onion skin or onion peel periosteal reaction. Onion peel appearance. The diagnosis is Ewing's sarcoma. In that case, the diagnosis is Ewing's sarcoma. So this was about bone tumors, correct? So we move on to the next question. 75-year female has chronic backache and X-ray spine is shown. So actually it's not an X-ray, yes, it's a CT scan, a non-contrast CT. Okay, the NCCT spine is shown below. What is the most likely diagnosis? So in this NCCT, what do we see? We see these prominent trabeculae and these compression fractures involving all the vertebra. So this is known as a fish mouth appearance. And since the trabeculae are very well visualized, we know that the bone mineral density is reduced here. So the answer here is osteoporosis. So port spine will have bony destruction, not compression fractures. It will destroy the trabeculae as well. Spondylolisthesis will actually have some displacement of this vertebra. So like this will be how spondylolisthesis will look like. It will have displacement of vertebra. Spondylodiscitis is nothing but infection of the intervertebral disc and the adjacent bones. This is again seen in TB and it will be seen on a contrast enhanced MRI. Okay. So this is how a DEXA scan looks like. DEXA is the investigation of choice for osteoporosis, and in DEXA scan we calculate T score. Okay, so T score less than minus 2.5 is pathognomonic of osteoporosis. If the T score is between -1 to -2.5, it tells us osteopenia. Okay. Now let's move on to the next question. How does a pot spine actually looks like? So the answer here is a pot spine. I'll tell you how does it look like. So there is this intensely enhancing soft tissue in which is causing destruction of this whole vertebra. Okay. Similarly, what do you see? That this vertebra has also enhancement. This vertebra also have destruction, and the soft tissue is extending through the posterior epidural space into the adjacent vertebra. So there is this subligamentous spread of infection. This is pathognomonic of Pott's spine. So you see subligamentous spread. This is how a Pott spine looks like. Now coming on to the next question, a 45-year-old male patient complains of recurrent swelling on one side of the neck. She is afraid of eating food as it worsens the swelling. Imaging is provided. What is the diagnosis? So in the floor of mouth, we see this well-defined calcific opacity. So this is nothing but a stone. And based on the expected location of the stone, the history of swelling on the one side with pain at the time of eating food, so we can safely assume that maybe this stone is obstructing your submandibular gland, so that's why there is swelling in this region, and again because of that the patient feels pain. So this is how a silolithiasis looks like. Okay, silolithiasis is stone in salivary gland, and in this case it's a submandibular silolithiasis. Okay, so this is how a stone looks on non-contrast CT, and how does the stone looks on an MRI. Now, which is this C investigation which has been shown to you? So here you see that the CSF in the spine is appearing so bright, and the rest of the soft tissue has been suppressed. It's appearing black. And which other thing is appearing bright? We see this fluid in this duct. Okay, this duct which is draining from the submandibular gland. So this arrowhead shows the submandibular gland, and that is the duct, the Wharton's duct, that is draining into the floor of mouth. And within this duct, we see this filling defect. This is how a stone looks like, and this investigation is known as MR silogram. This is known as an MR silogram. Okay, now let's move on to the next question. Some bone tumors will quickly read. CT scan image of a solid cystic lesion with calcification in the sellar region. So sellar, cystic, calcification, 1C that is missing in the question, will add a child. Okay, so whenever these four buzzwords are given, child, cystic, sellar, calcification, then your answer will be an craniopharyngioma. Okay, now how does an oligodendroglioma looks like? The option C, how does it look like? First of all, oligodendrogliomas occurs in middle-aged females. First point. Second point, there is preponderance for frontal lobe involvement. Frontal lobe involved, and genetically or pathologically, they have one characteristic mutation, that is 1p19q deletion. 1p19q deletion is pathognomonic of oligodendrogliomas, and these are low grade gliomas. So this is how an oligodendroglioma looks like. You can have calcifications also. Yes, so oligodendroglioma can also have calcifications within. on a non-contrast CT. So this is how a non-contrast CT, you see this mass in the left frontal lobe which has calcifications within, correct? And on T2 weighted MRI, it is showing T2 bright signal, and it is involving the cortex and the subcortical white matter of the left frontal lobe. So this is how an oligodendroglioma looks like. So some buzzwords regarding this was calcification, females middle-aged, frontal lobe involvement, and cortical based tumor. So it is a frontal lobe cortical based tumor. Now, which is this first tumor that is shown here? We see this intensely enhancing tumor in the left CP angle, cerebellopontine angle on the left side, and this tumor is extending into the internal acoustic canal like an ice cream cone. Like an ice cream cone. This is nothing but a vestibular schwannoma. This is how a vestibular schwannoma looks like. Okay. Now let's move on to some neck pathologies in children. A 2-year-old child presents with low-grade fever and stridor, and on an X-ray you see this subglottic narrowing. This is known as the steeple sign, and it is seen in croup, also known as laryngotracheobronchitis. So this is acute laryngotracheobronchitis caused by parainfluenza virus. Similarly, if in a child you see this narrowing of the nasopharyngeal airway, this is adenoid hypertrophy. And if there is widening of the prevertebral space, there is widening of prevertebral space, this is a retropharyngeal abscess. This is a retropharyngeal abscess. Now, another important sign, again a child will come to you with high-grade fever and stridor, and on a neck X-ray you will see this enlarged epiglottitis, giving it a thumbprint sign. This is a thumbprint sign seen in acute epiglottitis. Acute epiglottitis. Now moving on to the next question, we have some anatomy questions of the foot and identification. So identify the bone mark. It's a simple one-liner. This is a navicular bone, so we label this as navicular. Other bones we label. This is the cuboid bone. This is the talus. This is the calcaneum. And these three are the cuneiform. So on a lateral foot radiograph, this is the calcaneum. This is the talus, the navicular. This right here is the cuboid. The AP foot radiograph I've already labeled, and on a hip and bilateral pelvis and bilateral hip X-ray, we see that these two are the SI joints. These are the SI joints, correct? This is your hip joint, the head of femur, neck of femur, the trochanter, greater trochanter, lesser trochanter, the superior pubic ramus, the inferior pubic ramus, correct? Now on the left hand side, we see that there is narrowing and destruction of the left hip joint. Okay, so this is pathologically involved. Now this can be TB, this can be osteoarthritis. We'll have to look at the history. Similarly, on a shoulder radiograph, what are the structures that are marked? So this is the humerus, the humeral head, and the humeral head articulates with the scapula. So the part of the scapula that articulates with the humeral head, that is the glenoid cavity. And apart from that, the scapula has two important other processes. One is the coracoid process, in which the short arm of biceps brachii attaches and the coracobrachialis attaches. And then there is another acromion process. This is how an acromion process is located. So on an elbow x-ray, we have few important structures. So the medial epicondyle, the lateral epicondyle, the ulna, the radial neck, the radial head, and the capitellum. So the part of the humerus which articulates with the radius, that is the capitellum, whereas the part of the radius which articulates with the ulna, that is the trochlea. Okay, remember this point. So on the wrist, again we have various carpals and metacarpals. You can remember them with any mnemonic. My favorite is like typical oldies mnemonic of Snehilata, Tinde Pakao, Tinde To Kache Hain. So you can form your own mnemonics as well. The new mnemonics are always available. So scaphoid, lunate, triquetrum, trapezoid. Okay, this is the pisiform. Okay, then trapezium, trapezoid, capitate, and finally ham. Okay. Now, a female presents with pain and swelling over multiple peripheral small joints and deformity is shown below. What is the likely diagnosis? So, what kind of deformity, first of all, we are seeing? We are seeing swan neck deformity. And in the background of it being a female patient and multiple small joints involved, so the diagnosis is pointing towards a rheumatoid arthritis. So, rheumatoid arthritis typically involve the small joints of hands and feet, and in the small joints the PIP are involved and DIP are typically spared. But RA can involve the large joints as well. And if the large joints are involved, first of all remember the distribution will be bilateral and symmetrical. That is, both the weight bearing and the non-weight bearing part, both of them will be involved. So in the hips, the superior part is the weight bearing part, that is involved, but even the medial part, that is also involved. And we see that the bilateral acetabuli are protruding into the pelvis. This is the protrusio acetabuli. This is the protrusio acetabuli that we see in RA. And similarly in knee, both the medial and the lateral compartment are involved. Both the medial and lateral compartments are involved. In the cervical spine, RA can also involve the cervical spine because the pannus that is formed in the RA can erode the atlas and the axis. So in the cervical spine, it causes atlantoaxial instability. And how do we measure atlantoaxial instability on X-ray? We see this distance between the dens of the atlas axis and the anterior arch of atlas. So if this distance is known as the atlantodental interval, that is distance between the anterior arch of atlas and the dens of axis. So if the ADI is more than 2 mm, that is suggestive of an atlantoaxial instability. Okay. Now, similarly to other, since we're talking about the various arthritis, so one of the arthritis which affects the DIP, I told you RA spares the DIP. So if involvement of DIP is there and involvement of spine is there along with some skin lesions, so small joint involvement plus spine involvement plus some skin lesions are there, so then we are dealing with psoriatic arthritis. Okay. Now in psoriatic arthritis, we see some exuberant periostitis, exuberant new bone formation, exuberant destruction, and that gives us a pencil in mortar appearance seen in psoriatic arthritis. Now coming to a very important question, a very important arthritis, famous for all examiners. A 34-year-old male complains of lower back pain since 6 months. He was previously diagnosed with case of ulcerative colitis of the colon. An X-ray of the lumbar spine is given below. What is the likely diagnosis? So we are seeing a low back ache, a young male. Okay, it's a young male, low back pain for 6 months, and there is a ulcerative colitis history as well. So on an X-ray, what do we see? We see first there is fusion of the spine. These are nothing but syndesmophytes. And we see this calcifications along the spinous ligaments. This is known as a tram track sign. This is known as a tram track sign, and it is seen in ankylosing spondylitis. Okay, so other signs of ankylosing spondylitis, first of all, remember the disease starts in the SI joint. So the first joint to be involved is the SI joint, and there occurs sacroiliitis. That is inflammation of the sacroiliac joint. Now, whenever there inflammation will be there will be bone marrow edema, and this is how a bone marrow edema looks like for ankylosing spondylitis. Now, investigation of choice for sacroiliitis becomes MRI, and with sequence in MRI, we do a STIR sequence, short tau inversion recovery sequence, that suppresses the bone marrow fat, and hence the edema appears very bright. So, investigation of choice is an MRI. What are the other signs that we see in ankylosing spondylitis? First of all, there is a shiny corner sign, because we know that there are syndesmophytes. So at the insertion of Sharpie's fibers, there is inflammation. So we get the shiny corner sign. We get this shiny corner sign, or Romanus lesions also, these are known as. Now, which is the second sign that is shown here? This is the dagger sign, due to this calcification of the interspinous ligament. Now, this is the tram track sign that we've already learned in this question. This is the tram track sign. And if there is fusion of the whole spine through syndesmophytes, then finally it forms a bamboo spine. Now, what is the test that we do? A clinical test that we do for ankylosing spondylitis? Tell me. Yes, it's a modified Schober's test that we do for ankylosing spondylitis, right? Now, coming on to another arthritis, a diabetic patient. Okay, risk factor, we have a diabetic patient, and we are given an X-ray. So what do we see? We see huge destruction. Okay, the bones are destroyed. The joint is distended. Multiple debris is seen within this joint. So what type of arthritis? It's a neuropathic joint, also known as a Charcot's joint. So in Charcot's joint, we have typical 6 Ds that we talk about. Okay, so we have destruction of joint, we have disorganization, we have debris within this joint, we have joint distension, we have dislocation of various bones, and the individual bones have increased density. These are the 6 Ds associated with Charcot's joint, and it is mainly seen in any neuropathy. So be it diabetes, be it syringomyelia, be it peripheral neuropathy. So all these will have Charcot's joint. Now the next arthritis is again a very commonly arthritis in elderly female, complaints of pain in the knee, which increases on subsequent walking. So we are talking about a non-inflammatory type of arthritis which increases on activity. So the prototype of it being a osteoarthritis. And on an X-ray, what do we see? We see asymmetric joint space narrowing. Asymmetric joint space narrowing, that is the weight bearing part of the joint that shows narrowing as compared to a non-weight bearing part. So On the hip, the superior compartment is the weight bearing part. So in the hip, the superior compartment is involved. So asymmetric joint space narrowing, the weight bearing part of joint is involved. Now coming on to the next musculoskeletal radiograph. The radiograph obtained from a child with skeletal abnormality. What is the name of the angle being measured? So first of all, if there is a F-type curvature of the spine, what will be the skeletal abnormality? Yes, it is a scoliosis. And scoliosis is defined by Cobb's angle more than 10 degrees. So which angle are we measuring? We are measuring the Cobb's angle. So Bowler angle, where do we measure? We measure Bowler angle in foot. So this is how Bowler's angle is measured in foot, and it's used for calcaneum fractures. Now Powell's angle is used in neck of femur fractures. So this is used for neck of femur fractures. And then Ferguson's angle is seen in, is also known as sacral angle, LSA. And it is mainly used for spondylosis or spondylolisthesis. Okay, so that's how a lumbosacral angle or a Ferguson angle is used. Now let's come to some GI spotters and GI previous questions. A barium swallow image is given. What is the most likely diagnosis? Okay, I think a lot of you will mark this correct. That yes, you see this abnormal shouldering, sudden cutoff, and this irregularity within the lumen. Okay, so this looks like a malignant growth in the lower end of the esophagus. So the answer here is CA esophagus. Again, this second image shows us this irregularity of the lower end of the esophagus, suggestive of a malignant pathology like a CA esophagus. In contrast, if you see a smooth narrowing of the distal esophagus and the gastroesophageal junction, then that is what a bird beak deformity is known as, and it's suggestive of achalasia cardia. Correct. Now let's move on to the next esophageal pathology. So the patient will have 50-year-old female comes to the OPD with complaints of dysphagia and chest pain. So dysphagia with chest pain, a typical this is a typical patient profile of a diffuse esophageal spasm. Okay, the patient was evaluated for barium swallow, and what do we see on the barium swallow? We see corkscrew appearance of esophagus. So the diagnosis here is diffuse esophageal spasm. Now let's move on to some women's imaging spotters. A female with infertility underwent hysterosalpingography. Following images obtained, what is the diagnosis? So first of all, which is the cannula which is used for HSG? This is the Leach-Wilkinson's cannula. And what do we see in this image? We see that both the fallopian tubes are dilated. Both of the fallopian tubes are dilated, and there is no peritoneal spill. So the answer here is bilateral hydrosalpinx. Okay. So other HSG spotters which are important. If you cannulate the cervix and only one side of the uterine horn is opacified, then other side fallopian tube is not opacified, then you suspect a unicornuate uterus. Okay, if there are two cervix, two vagina, and you have to cannulate them both individually, then that becomes a uterus didelphus. Similarly, if there are two uterine horns, each of them showing their own peritoneal spill and they are wide apart, then that is a bicornuate uterus. Okay, but if the angle of separation between the two uterine horns are not so much, it's less than 90 degrees, and there is a common cervix and a common vagina, then you are dealing with the septate uterus. Now, if both the cavities are not so separate, but there is some indentation on the fundus of the uterus. So this is an arcuate uterus. And if it's a T-shaped cavity, this is des-related anomaly. Diethyl stilbestrol, that related anomaly of the uterus. So this is the classification of Mullerian anomalies. Now, if you're asked investigation of choice for Mullerian anomalies, and you are given the option of MRI and TBS, so in that choose MRI. But if you're asked gold standard for Mullerian anomalies, then the answer to that is a diagnostic hysteroscopy plus laparoscopy. DH plus DL. Okay. Now, another important women's imaging spotter, a 35-year-old female presents to you with history of nausea and vomiting. She is undergoing an IVF treatment. What is the likely diagnosis? So we see that the bilateral ovaries are bulky, they are very large, and they have these multiple follicles within. Now, these multiple follicles are not very small, they are big follicles. Okay, so it can either be a thecal lutein cyst or it can be OHSS, but in the options we are given that patient is going IVF treatment, so the answer here will be OHSS. So similarly to that, if you are given multiple small follicles, multiple follicles are there, but the individual follicles are very small and the ovaries are bulky, in that case the answer will be PCOS, polycystic ovarian syndrome. And the question can be asked, what is the diagnostic criteria known as? Diagnostic criteria is known as the Rotterdam's criteria. Rotterdam's criteria for PCOS. Now coming on to the next question, a middle-aged female with sudden onset headache and neck rigidity. There is no history of trauma. NCFT is given below. What is the probable diagnosis? Okay, so headache and rigidity, we might be thinking of meningitis, okay, but it is a non-contrastivity that is given to us. You do not see any contrast in the blood vessels of the brain. And what do we see? On the left hand side, we see some hyperdensity within the sulci. So this is a subarachnoid hemorrhage mimicking a meningitis, because subarachnoid hemorrhage bleed, can irritate the meninges and you can get secondary neck rigidity there. And it's a non-contrast CT. There is no enhancement that we can pick up on the CT. So we'll choose the option of a subarachnoid hemorrhage as the correct option. Now, a head trauma is one topic that is very important for FMG exams. So 36-year-old male underwent a RTA, NCFT is performed. What is the diagnosis? I think the answer is pretty clear. We have this biconvex bleed in the right frontoparietal convexity, and it is not crossing the suture. So you have one suture here, you have one suture here, and it's not crossing it. So it is an EDH. Now, how do we differentiate from an FDH? So FDH will cross the suture. It will be a concavo-convex. It will be a concavo-convex bleed, and it will cross sutures. Okay, this is how a SDH looks like, subdural hemorrhage. And in an SDH or an EDH, especially in an EDH, what do we have to really think about? If there are these hypodense areas within this EDH, then they signify an active bleed. An active bleed is hypodense on CT scan. And this tells us that yes, we need to be cautious. This patient might need an emergency decompressive craniectomy. And the ultimate decision to perform a decompressive craniectomy is taken by calculating your midline shift. So you draw one line through the center of the brain, that is through the septum pellucidum, and one line through the center of the cranium or the skull, that is from the line from the crista galli to the occipital protuberance. And if this shift is more than 5 mm, then we take the patient for decompressive craniectomy. Now moving on to the next question. So just a direct spotter, what is the likely diagnosis based on the given image below? So you see a bulky uterus, a enlarged uterus with these multiple small cystic contents within it. So this is what is known as a snowstorm appearance, or a bunch of grapes appearance, seen in molar pregnancy. Now similar to that, another spotter from a women's imaging is seen if the patient is UPT positive, she has acute onset pelvic pain, she has had amenorrhea for 2 months, and you do an ultrasound, you see a cystic structure in the adnexa, you put in a Doppler and you see this peripheral vascularity known as a ring of fire appearance. This is seen in ectopic pregnancy. Now the next question is that related to foreign bodies. Very, very important. Recently asked in INICT. So 9-year-old baby was brought to the emergency by the mother with difficulty in swallowing for the past few hours and a history of playing unsupervised. An X-ray was taken, identify the location of the foreign body. Now remember that the larynx, is located anterior-posteriorly. So if this is the larynx, this is how the vocal cords are placed, So if the foreign body has to be in the trachea, on a frontal X-ray, it will appear end on. That is the only way it can pass through the larynx. So if on a frontal X-ray, you are seeing the foreign body as big round structure, remember that it will always be in the esophagus. So the answer here is the location is in the esophagus, and on the lateral X-ray it will be vice versa. On the lateral X-ray in esophageal, foreign body will be visible end on, and a tracheal foreign body like this, tracheal foreign body will appear big round. So this is a tracheal foreign body, and this is an esophageal foreign body, correct? Now another pathology that is seen on the lateral aspect of the neck, especially you might be given in the question that a trumpet blower develops a swelling on the lateral aspect of the neck whenever he blows the trumpet, and on an X-ray you see this air-filled cavity on the lateral aspect of the neck. So this is how a laryngocele appears. Okay, laryngocele appears. And another two pathologies that we have already read, one is an acute epiglottitis, in which we see this thumbprint sign on lateral X-ray of the neck, and then another was in croup or laryngotracheobronchitis, in which we see this steeple sign. So that was all from this radiology class today, the Guess the Paper series of radiology. We have discussed around 70 around good number of questions, along with some additional questions which are relevant to that topic, and I hope a lot of things are covered for you in radiology. Thank you.